It seems as though genetics is as important as these great new surgeries that we've been hearing about. And I sincerely believe it's going to change the way we think about glaucoma. And I'm speaking to you as a clinician. I'm allowed in the lab. I'm not allowed to touch anything. So I'm going to talk to you about what it's my role as a clinician, which is what you guys can do in being involved in genetics research. So we all know that glaucoma is a family of diseases, share nerve fiber layer loss, optic nerve head, cupping, visual field loss, and that family history is a major risk factor for many of the glaucomas. And the point of this talk is that we can use that heritability. And I'm going to talk about three things: identifying patients at risk, genetic testing, and then searching for disease-causing genes. So you need to ask your patients about their family history, and more importantly, you need to tell the patients about the risk to their family of developing glaucoma. For me, if someone has a positive family history, particularly of severe glaucoma, I'm much more likely to treat them if they have ocular hypertension. And if patients have a strong family history of glaucoma, I usually get baseline disc photographs. Just for an example, we have a 51-year-old man, positive family history, pretty normal examination, but he said, well, when I was 22 years old, Dr. Phelps, who was my predecessor, took photos of me in 1978. And you can see that based on his old photographs, he's had progressive cupping. So I think disc photos in people who are high risk for developing glaucoma are worth doing. Tell the patient about the risk to their first-degree relatives. For diseases like juvenile open-angle glaucoma, which I'll talk a lot about, and Rieger syndrome, aniridia, the risk is close to 50%. We know that screening for glaucoma is not typically very cost-effective, at least the way we do it today. But screening first-degree relatives would be a much better use of our resources. In the Rotterdam study looking at individuals with primary open-angle glaucoma, they examined first-degree relatives of patients with open-angle glaucoma and controls and found glaucoma in 10.4% of siblings of patients and only 0.7% of siblings of controls, which is a 15-fold difference. So that would be a great group to screen. Ask them to get their brothers and sisters to come on in and be examined. More importantly is an angle closure glaucoma, and really a shout out to Kavitha and all of the group here for this tremendous study. I don't have this in here because I'm talking in Pondicherry. I have these slides no matter where I talk. But they did this study where they did mass gonioscopy on siblings of patients who had open angles, another group were angle closure suspects, and then a group of primary open angle glaucoma patients. And they found the risk of angle closure in open angle glaucoma individuals to be about 4%. But if somebody was an open angle or angle closure suspect, that risk jumped to 35% and was similar in patients with frank angle closure. And 11% of these actually had angle closure at the time they were examined. So this is a very rich pool of people to evaluate. These are people you should be seeing, first-degree relatives of patients with angle closure. We can do genetic testing. We don't do it very often. When might you do that? So this is a patient who has nystagmus, pannus, and a cataract, but he has an iris. All of those features other than having an iris would make you think about aniridia. And you can have aniridia and have an iris. Sounds odd, but you can. But you can test this person for PAX6 to see if they have a mutation in that gene. The main thing I'd like to talk about is finding new genes, because you guys have big families, you have great clinical care, and this is a place that would be rich for finding new genes. I've been really lucky to be involved in finding quite a few genes for glaucoma, and I'm going to talk about three of them. One is myocillin. So myocillin started for us in 1986. This man came in a year before I got to Iowa asking for a trabeculectomy. He had recognized that everyone in his family who had had a trabeculectomy was still seeing, and the people who hadn't were all blind. And he brought in a family tree, and we put it together as this pedigree that we published in 1993. We linked that gene, that disease, to chromosome 1q, also in 1993, a linkage site called GLC1A. And then we found the gene in 1997, mycilin, and this has been repeated around the world. Mycilin, most people who have most mycilin mutations act like this, where this is this man's mutation. They have early age of onset, 20 years, high peak intraocular pressures, 44 millimeters of mercury. There are variations in mycilin, however, the stop mutation, where the age of onset is pretty normal for glaucoma, 59 years, peak pressure is not too startling at 30 millimeters of mercury. So it causes virtually all autosomal dominant juvenile open-angle glaucoma. If you see somebody whose angles are open, they're 30 years old or 25 years old, and have pressures of 55 millimeters of mercury and a family history, they have a mycilin mutation. Also causes quite a bit of juvenile open-angle glaucoma that's not familial, and also causes 3 to 5% of primary open-angle glaucoma in most populations. Just another point of being an observant clinician, this is a patient of mine who I saw who had multiple abnormalities from a chromosome 613 translocation. She had feeding problems, mental developmental delays, skeletal problems. And as a clinician, non-scientist, I just asked people in the lab, is that interesting? Could her glaucoma be caused by this break in her chromosome? And Daryl Nishimura was able to find FOXC1 gene just in this one little girl. So you just have to ask the right questions. We're also interested in components of glaucoma. So this is a patient of mine who has LAD syndrome, something I'd never heard of until I met him. It's lacrimo-auriculodental digital dysplasia. You can see his very unusual digits. He has very poor saliva and tears, so he has pannus and he has bad dentition. This man is a graduate student in mathematics, so he's a very smart guy, but he's very dysmorphic. He's in his early 30s, and he has severe visual field loss, and he has the thinnest corneas I've ever seen. 193 microns on the right eye, 284 on the left. So the question is, could figuring out his genetic defect help us to understand corneal thickness gene? Could that be a gene that we can use to study glaucoma risk? And we just recently published this new gene, TP63. So the important thing to remember is that clinicians, it's not the lab people, they're never going to find these families. You're going to find them in your towns. Not all of these great families are in Iowa. TBK1 gene is from Alan Robin, a patient with dominant normal tension glaucoma that we were able to, John Fingert was able to link to chromosome 12, and we found a duplication of this gene called TBK1. So what? I mean, so we find these genes, what are you going to do with these genes? And I think that there are a lot of things that we'll be able to do going forward. I'm going to talk about two of them just because we have limited time. One is pre-symptomatic diagnosis. We saw this pedigree. This is the proband of our family. This is his nephew who lives in Georgia, which is quite a ways away from Iowa. He had early onset glaucoma, had 3 surgeries, and he came to Iowa with his 2 daughters. And he said, are they going to have the same disease as his family? I put the study numbers up there just to let you know that this is the 131st and 32nd member of this family that we've evaluated. It's a huge family. And let me just take a little detour and talk about how bad mycilin is, because I see a lot of mycilin since the 2 biggest families are near us. This young woman, her mom, I operated on when she was 16, and she had 3 pregnancies, seemed to do okay, pressures were always in the low 20s. But during her 4th pregnancy, she just decided to stop all her medicines, and she also stopped coming in for follow-up visits. In the last month of pregnancy, she came back because she wasn't seeing very well. And her pressures were 41 and 60. Wide open angles, normal trabecular meshwork, at least to our exam. And this is what had happened to her optic nerves in those 9 years. And these are her visual fields. So you can see why this man is worried about his children. And thankfully, I was able to call him and let him know that they're both negative. And so they have no more risk of this disease than my children do. And lastly, trying to understand something about glaucoma at a molecular level. You know, when I see somebody with primary open-angle glaucoma, I treat them with prostaglandins. And then if they have exfoliation or pigmentary, I treat them with prostaglandins. And you know, if their pressure's normal, I treat them with prostaglandins because I don't know any different. I treat everything in some ways the same. We don't really understand a lot of the pathophysiology of glaucoma. But in mycilin, we now understand quite a bit. So we've been able to make a mouse with a human mycilin gene. This mouse has high intraocular pressures, a transgenic mouse at the top. We measure the pressure at nighttime because that's when it's highest. They lose ganglion cells. We know now that normal mycilin is secreted into the aqueous, and mutated mycilin doesn't get into the aqueous. It stays in the cell. So the path of normal mycilin is to go from the nucleus to the endoplasmic reticulum, Golgi apparatus, into the aqueous humor. But in patients who have mycilin mutations, the mycilin protein gets folded, it forms aggregates, it stresses the endoplasmic reticulum, and it leads to cell death. So this gives us a target. Can we make the proteins unfold or fold properly? And there are drugs called chaperone drugs that do just that. They can cause unfolded proteins to fold properly and be released. So one of these drugs is phenylbutyrate. It's used to treat a rare kidney disease, and it's systemically safe. And if you treat mice with this, so this is a normal wild-type mouse, if you treat it with phenylbutyrate, nothing happens to its pressure because the system's already folding properly. Transgenic mouse with a high pressure that normalizes with phenylbutyrate. It rescues ganglion cells, so this is untreated and treated compared to the wild type on the left. And we've actually shown that with topical phenylbutyrate has the same effect in making the pressure normalize. And to me, the exciting thing is that we're actually fixing what's wrong. So maybe you don't have to take a drop 3 times a day. You can maybe take it once a week or once a month. And it's exciting. I think this is exciting conceptually that instead of always treating people with the same medicines, we would have designer drugs. And I personally feel that misfolded protein is probably more of a problem than just with mycilin mutations. So in summary, ask about the family history, tell them about their family risk, think about genetic testing very rarely. I can do it for free. I almost never do it. Keep your eyes open for the next great family. You guys have great molecular biology at Aravind. Dr. Sundaresan we've worked with for many, many years. You actually have someone you can go to and say, I think I have a great family. What do I do with it? And I think that new therapies based on molecular biology are in the foreseeable future. Thank you.